Thank you, gents, for a really exhaustive review and a detailed review of thymectomy, thymoma. No wonder you are the leading expert in the world on thymic diseases. And the world looks at you and your data, and we follow what suggestions you give. So thank you once again. The session is open to the floor for questions, please. This is a very controversial topic, so this is the place to ask questions. I'll start off by the first question, gents. There are people across the world who are doing thymectomy from the right side. Are they doing it wrong? That includes me.
Yes, the question most often in discussions mentioned, and my answer is you cannot answer in one sentence, but I try to be short. There will be a publication addressing that question. Only that question will be to be read soon, I think, I hope. But in the analysis have to be included the typically right-handed surgeon says it's more convenient coming from the right side. The easier anatomy at the beginning is to go along the vena cava, having the phrenic, having the thymic gland, looking for the venous confluence, and from there being able to reach the neck and the right side. Of course, predominant right-sided thymoma. What about then coming from the left side? In almost, let's say, in over 90% of the cases, in my experience, and you might judge upon that in your ongoing experience, compare right and left part of the thymic gland. Almost always the left side is the bigger one, the larger one, not only the main lobes, but also the as to the cervical pole. That makes it clear that coming from the left side is more necessary. Our anatomy study at the beginning defined a better radicality coming, if you want to go unilateral, then better to come from the left side. You find the thymic gland extended beyond and above the phrenic nerve in many cases, macroscopically to be seen, to be followed, with the necessity to enter the aortopulmonary window. It is difficult coming from the right side, even with CO2 insufflation, with enlargement of the operation field, and it is not with an initial experience. It is not a very, very difficult way to find the innominate vein at the left side. So there are arguments for each procedure. Let me add that in the past I saw one publication of Anthony Yim from Hong Kong, one of the beginners of thoracoscopy in the past, and he switched from the left side to the right side for thymectomy. But if you see his photograph of the trocar sites, you see that he is much too below with his trocars, so that he will have difficulties definitely coming from the left side. My suggestion is to very extensively think about the positions of the trocars in ideal position for the patient you have on the table. This is the guarantee of success.
There is a group from the US who are doing extended radical resection thymectomies with the transcervical approach with the substernal retractor, where they actually hang the patient from the sternum via the retractor. Do you think we could approach the mediastinum from the top with the robot?
The ENT experience makes clear that this is possible. This is possible. All the colleagues doing that procedure will tell you, well, we developed the technique by introducing a camera. Think about Marcin Zielinski, this Polish thoracic surgeon with his extensive lymphadenectomy via a thoracoscopic, via a transcervical excision. And everyone will tell you, well, the camera, if we are experienced, the Toronto group says, Geschäftschi, and so we don't even need a camera. This is traditional technique, from my opinion. The area of the thymic gland needs an overview, which is perfect with thoracoscopy under robotic dissection. And we know all the approaches. We have respect for the experience of the subxiphoid, of the combination of transcervical subxiphoid or both-sided thoracoscopy, with the Italian guys doing that, but as far as I know, they don't do it anymore. Under the influence of the data, it's possible to be more minimally invasive by avoiding a four-side approach for thymectomy. It's better to have a minimal number of trocars, but a meticulous technique of dissection.
In private conversations in the UK, a lot of surgeons, and you were saying this as well as myself, that a lot of surgeons have admitted that they, in the case of a thymoma, they would go in and just do a thymomectomy, just take out the nodule, and they don't have the data to support their results, but they say that it works. Do you think that's the way forward? Just do a thymomectomy rather than take the whole thymus out?
Never, because all the material, the ITMIC, this International Thymic Malignancy Interest Group, which is really a prestigious society meanwhile, all the material they collected would be in vain. And on the other hand, this was the additional topic I had. On the other hand, I tried to find data, pro and con, this question, and one of the surgeons with well-known surgeons is Waller in the UK, who really admitted that or stated that, and I found data of him even to suggest that it will be an interesting discussion.
I mean, Waller talks a lot anyways, if you know him personally. Another question of clinical relevance, which I have sort of faced. What is the role of preoperative fine needle biopsy, CT-guided biopsy, in a case of mediastinal thymoma, suspected thymoma? Should you do it or should you never do it?
I would like to show 3 slides to answer that question. If I find them, there are guidelines, and the guidelines are like this. If you have a prime, I'm looking for the slides. This is not the slide I mentioned, but I describe it. If you have a mediastinal mass looking like a possible thymoma, being resectable by all criteria, no needle biopsy, resection. Of course, that means exploration and resection or extension of the operation or step back, no operation. It's a perfect way to explore a thoracoscopy. Yeah? And if there is a primary questionable resectability, then there is a place for a needle biopsy to clarify if that is lymphoma or thymoma or something else. With the need then to go another way with a neoadjuvant chemotherapy for thymoma before resection, because nothing is as bad as an R2 or even R1 resection with a thymoma. Sure. Therefore, this would be the strategy, or otherwise a definitive chemotherapy without any place for surgery at all. Therefore, the biopsy is necessary in all cases with questionable primary resectability.
Frank Ditterbuck, in one of the conversations I was having with him, he had a philosophy where he said that the prognosis of thymic cancers depends on the invasion, a capsular invasion, long-term prognosis and outcomes. And he says, you put in a needle into a suspected case, then you are actually causing cancer cells to come outside the capsule. So what would be a stage 1 would probably move on to stage 4. And so, you really have to think long and hard before you put in a needle into a mediastinal mass. What do you think about
this is Frank explained, yes, this is an important question. Nevertheless, it's if you look for data of approval of a spillage because of needle biopsy, it will be hard work. This is one thing. The other is, if you really have this questionable resectability, it's necessary not to harm the further case by avoiding a histology and then maybe a breakthrough of the thymoma intraoperatively.
Okay, any more questions?
Sentinel node was negative, but in the workup there was a mediastinal mass with high activity, high SUVs in the PET scan. What to do? Primary resectable. Differential diagnosis, metastasis of melanoma or thymoma or something else. We took that way, primary resection with a robotic device. Meticulous, complete resection, complete thymectomy, in the sense maybe this is a thymoma. In the end, it was Hodgkin's lymphoma. I think you address especially these cases. No harm for the patient, because on the second day she was ready to leave the hospital and very soon ready to undergo the therapy, even if there was no visible Hodgkin lymphoma anymore. If that would have been a melanoma, any biopsy would be terrible, and for a thymoma, not necessary. So you will have these cases, and again, it's, for my opinion, it supports the opinion to making it depending on resectability and then go with surgery.
How much difficulty you find while operating a patient of thymoma with a superior vena cava syndrome? Is it different difficulty grade is more with the robotics, or?
The vena cava syndrome would keep us away from surgery, keep us far away from surgery, because most of these cases, there are exceptions of advanced stages of thymoma, of course, but they are not primary candidates for operation, not primarily.
Not primarily.
Not primarily. And most of these cases are not thymoma patients. I could add dozens of actual slides to that question. But of course, you might mention, or you are thinking about the extended operations for thymoma. And I know at least 2 centers. One is in Vienna, Klepetko, Walter Klepetko, having done the biggest number of lung transplantations meanwhile, having published on that, and the other one is Cameron Wright in the Mass General, with beautiful pictures of extended operations with vena cava syndrome and superior other veins included, but these are exceptions.
And what about the remission rate? Is it partial remission or a complete remission How much was complete remission after robotic thymectomy?
Remission of myasthenia gravis.
Yes.
As I showed, it's exactly 43% in our hands.
It's complete remission.
Complete stable remission, meaning 1 year at least without medication and without symptoms, and analyzed not only by the surgeon.
Which group of patients? I have two questions. First for Dr. Jains. Sir, which group of myasthenic patients do you think do well after surgery? Those with thymoma vis-a-vis those without thymoma? And the second question for Dr. Zamir. Sir, we have heard Dr. Jains talk about the advantages of a left-sided approach. I'd like to know what is your take on the advantages of a right-sided approach.
I have not the typical data. With us, the thymoma patients have a quite good outcome of 25% in this group of 50 patients, robotic thymectomy for thymoma patients. If you take the percentage of myasthenic patients, it's above 75 to 80% of these patients. I think 40 of them have had myasthenia gravis, 10 of them not. Including these 40 patients with combination of myasthenia gravis and thymoma, you find 25% cumulative, the Kaplan-Meier analysis, cumulative complete stable remission in these patients. This is our result.
As regards to the right-sided approach, I started training with the right-sided approach because I trained with Alper Toker in Istanbul to start the Vatt's thymectomy program. I have done left-sided as well. I do left and right. It depends on what the patient needs, but predominantly the right side. One advantage is there's a lot of space in the right. There is easy accessibility, and one thing that I do different from what Jens does is I noticed he opens his right pleura at the end after he's done the thymectomy to look over, whereas I go from the right, open up the pleura, go into the angle of where the pericardium ends and the diaphragm starts, and I start dissecting everything off there, and I go to the left side and I open the left pleura. Very, very early in the game, I open the left pleura. Particularly with robotics, my personal experience has been that with robotics, you can go over and look down onto the left phrenic and dissect everything off there. Jens was telling me that he's not convinced that I am seeing the aortopulmonary window adequately. I am very happy to do a few more cases from the left to see the difference between the two. But technically, I find right side easier than the left side. But you know, you learn along the way, and that's why you have to take on board opinions of leaders like Jens. So I will. My next two cases I'm going to do from the left side to see if I see the aortopulmonary better as compared to the right.
May I add at that point? It's about technique. The CO2, in my opinion, the CO2, or the same if from the right or from the left side, is working best. Think about the complicated patient and the anesthesiologist, not in the corner but in the center. If you get CO2 insufflation, and you lose the extension of the operation field as soon as you open up the other pleural cavity, and therefore it's our policy to wait with the incision, but only to see as a window the other lung, in our case the right lung, through the window of the pleural coverage, only the pleural coverage, but it extends very effectively into the neck and into the right side. You have the perfect view at the venous confluence, and if you open up in the end the pleural cavity, you, in most of the cases, you only check for radicality and have nothing more to do. This is because I would strongly recommend not to give up this advantage at the too early stage of the operation. You have the sight, it's quite clear with the instruments, with the angled camera into the other cavity, but the advantage of CO2 is a special one with one cavity.
I personally use the CO2 only for the start of the operation. I mean, it continues during the operation, but really I find that the CO2 advantage is at the start when you want to push the lung away and just start dissecting the mediastinum. After that, I think it does not add to the operation, but I will take your suggestion on board, and maybe next time we'll have another chat in another meeting where we might think differently. There are people in the world who do on the morning of the surgery or the night before, they take 50 cc's of air and they inject it transcervically into the mediastinum to develop the planes. It's a dangerous technique. I would not recommend it.
This is the Italian
the
group
Italian
from
group
Rome,
does that.
Pompeo Mineo,
Yeah,
very
Pompeo,
skilled surgeons. They operate on. Meanwhile, they specialized in COPD, operating in the awake patient. To avoid any intubation, it makes sense. But they told me this summer they gave up with the preoperative. This was an idea. They are honest surgeons. They gave up this technique. I think it's really not necessary to enlarge the space. You will have nice times with thymectomy if you for the first time don't open up the other cavity.
I am enjoying my thymectomy. I think I'm having a good time. So,
Sir, in the beginning of
Dr. Taha was going to ask.
Sir, in the beginning of the talk, you said that thymectomy is a strange operation. You said thymectomy is a strange operation when you began your talk.
Oh,
can you tell me why?
This strange means it's a rare operation, and these are always special, very individualized cases you have to address. And what I wanted to express, this is a colibri of the surgical work you have. Don't it's a very important thing if you want to be right with that operation, but and you have to go into all the details because this is only one life for one patient, and doing an operation. Well, I did it minimally invasively. How many videos I saw where you have almost part of the thymic gland even addressed with a resection, with a spatula or with a hook, of course away from the phrenic nerve, far away from the phrenic nerve, and and then we took only 1 hour 10 minutes. What is that? A result? Something good? No, never. So I strongly speak in favor of a rare, maybe sometimes strange, because of the different opinions on the sense, I did not include here, of this operation. Keep in mind that the study, the prospective randomized study, with I think 79 centers worldwide taking part for more than 6 years, did not recruit 100 patients in the operation arm to judge upon the advantage of thymectomy. If you break that down to a single center, there are many centers who did not include any patient. Maybe they perform operations, but patients did not want to be in that study. We thought several times about this, and the group performing that study is wondering themselves, and they think about the sense of the study. It's not a strong study if you operate in the study design maybe one patient in 3 years. So it's better to have 20, 30 patients a year to increase the experience and to do something for the patients.
Professor Arvind Kumar?
Yeah, a couple of thoughts about the issues. One was regarding the FNAC. If you have a patient of myasthenia who's a known myasthenic, and on CT scan you find a tumor there, putting one and one together, it's likely that it's a thymoma. When, as he rightly said, when it's a situation where it's an invasive tumor, very locally extensive tumor, where germ cell tumor and lymphoma are two important differentials, and even if it's a thymoma, it's the multimodality therapy which is the standard of care today. You would like to give them anterior chemotherapy. So there the diagnosis becomes important. So that's a clear indication for getting a tissue diagnosis. But in a typically resectable thymoma, in the setting of myasthenia, it can be avoided. One. Two, if you have any evidence of clear-cut involvement of SVC or innominate vein or going into aorta pulmonary artery, that patient is not to be considered for a minimal invasive approach. Let that be very clear.
Sure.
Thirdly, about this left-sided, right-sided, I have experience of over 150 thoracoscopic thymectomy done over the last 10 years, and then close to 60 robotic done with Jens as the guru in the last 2.5 years. Thoracoscopically, initially I started from right-sided approach, and then somebody came and he said that left-sided is better, so we tried a couple of cases with left-sided, and then I found that probably bilateral would be better. But having seen from both the sides, when it's a question of doing one-sided and you have to look over to the phrenic nerve on the other side, my experience was that finding right nerve and the tissue anterior to the nerve from the left-sided approach was better or easier view than finding the left nerve and the tissue anterior to that from the right-sided approach. And with the robotic approach, finding the right nerve and the tissue anterior to that from the left side with the ability to go over is very, very easy. And of course, he only has taught us, so we also keep the capnoperitoneum till the end. Because if you cut it right in the beginning, you lose that advantage of space. And it does, actually, when you put the scope, the moment you connect CO2, suddenly the space becomes more, and then the instrument movement becomes easy. Suddenly you find that you have a lot more space for moving these instruments.
Sure.
So this debate will go on, but probably the dissection of the opposite side is easier from the left-sided approach than it is from the right-sided approach.
Okay.
I was hoping that I can show two more
Yeah,
slides.
sure.
Is that possible? Then take this one. This reminds us, if you find such a tumor, small enough, thoracoscopic approach, 63 years old female, and myasthenia gravis, stage 3. But what we found was a very advanced stage 4A, Masaoka 4A. Even if it was a WHO B2, we know B2 is dangerous. This was one distribution. Here you can see that all the criteria of the CAT scan were not fulfilled for a minimally invasive approach, and other signs of questionable resectability. Nevertheless, we did, but we ended up in an extended pneumonectomy in that case. We had to perform a sternotomy in the beginning and to find out what is necessary here below, this was the first sign. In the end, we had to change the position of the patient to add a posterolateral thoracotomy and there was no necessity, no opportunity to leave any part of the right lung in that case. So small tumors should not mean well enough for minimally invasive surgery. Here was the slide of this 28 years old patient. Maybe we do it like this. Here you have the area of the resection after replacement of the pericardium, because a large part of the pericardium had to be removed. In the end, this was the distribution of the localized but stage 3A, I think, 4A, Masaoka 4A thymoma in that case. And here I show you the slide of this 28 years old female, which I mentioned with that lesion in the PET scan and with the end result of a Hodgkin.
Thank you very much, gents, for a really fantastic and comprehensive review of thymoma and thymectomy.